All right, hello everyone. This is AJ. I just wanted to have a couple announcements before we get started. I just wanted one thing I want to make sure for today's presentation is could everyone make sure that on the top of their screen that the microphone is the click on the microphone. If it's green right now, could you click on it to make sure it's white so that your microphone is not on? We've been having some issues with an echo on the recording, and I think that's the reason. So could you guys make sure that's off? And other than that, Andy, please take it away.
Great. Good morning, guys. This is Andy Principe from Starling Advisors. I have Amanda Stangus with me here. Amanda's been presenting for the last 2 weeks, so she's going to be getting this week off, and I'm going to be taking over the presentation responsibilities. Today, we're going to be discussing the structure, governance, and operations of effective networks, with a specific focus on the types of things, the types of activities that networks typically take on behalf of their members in order to drive efficiency, essentially, in how those members engage in various payment methodologies and payment relationships. Last week, at the end of the session, we had some questions for you folks, and we figured this would be a good time to kind of just do a little bit of a recap of last week.
Can you hear everybody here okay?
Because the information is relevant to today's conversation. Today's conversation will build on last week's discussion. So some of the questions we had posed were, what partners or organizations need to be represented in a network's governance model? Should the governance model be representative of specific provider types? How would you take things like geography into consideration? What type of initial participation requirements might be necessary? What types of committees would best support the network? And based on all of that, what are the risks that having a variety of different governance models might have on the overall success of the network? So with that, I believe, AJ, do we have the microphone? Do we have the audio open to all?
Yeah, it should be ready to go. Are people having some issues?
I don't know that they are. I just wanted to make sure before I ask folks to comment. We'd love to hear from you folks if you've had any time to think about some of these questions, or specifically in your particular case, if you have any questions that really kind of fit into the areas that were discussed last week. So feel free, anyone, to to comment or question, and we'll move on from there. Well, seeing as I'm not getting any feedback from the group, I'm going to call on someone I know well. Beth, I know that you folks are considering different types of partnerships in New Mexico. Can your team kind of comment at all on how they see or what they see as some of the challenges to governing those relationships?
Oh, Andy, I feel special. I guess at our stage, from everything you've shared through these VLCs and from the other, variety of sources that are out there sending information, it really needs to have a strong physician component and probably include FQHCs or RHCs, a lot of primary care providers. But we're not at that stage. Right now, we're just trying to figure out how the hospitals can work together legally and what clinical integration means. So if you are trying to push me to say something else, give me a hint.
No, I think that's helpful. So certainly there's considerations for how in your particular case, how the hospitals are going to interact amongst one another, the implications of that on certain legal issues. But then when the broader intervention gets rolled out, really having a voice for physicians because ultimately, and other clinicians, because ultimately it's going to rely on their efforts and work to make that essentially happen. Any comment, Beth, on the geography? I know geography plays a pretty important consideration in your market. Can you talk a little bit about how that creates some maybe stress on how any kind of value-based solution might work?
Of course. What I'm hearing is that for a payer to be interested in some sort of value-based or alternative payment model, there need to be at least 1,000 to 1,300 members that are involved. For the project, SNAC project we have funded in the northeast quadrant of New Mexico, these hospitals are 100 miles from each other, and the entire population is maybe 50,000 that we're talking about for the 4 hospitals for their catchment areas. So we definitely struggle with how many people would be affected by any project we created. But another factor for us is if these hospitals are supposed to be working together, they are so far apart. How do the pieces come together? What kind of scenario makes sense for collaboration when we're talking about geography of this nature? And I guess I think about the Eastern Oregon CCO that is literally half the state, and I think they provide some portion of a model to us because they cover such a vast geography that they aren't working together, but tied together financially because of the CCO model. And We're not at that. We will not financially integrate. It's a question of our path to clinical integration and what is rational.
Great. Thank you. Anyone else want to comment or ask a question? Okay, well, thank you, Beth. I'm going to move on. We did not have any questions. So in today's conversation, we're going to talk about the types of things that a network will typically do to support its members. There's a lot of flexibility in this, and there's absolutely no one-size-fits-all model. So we've really tried to focus on some of the highest value things that we see networks taking on behalf of their members. And these can be challenging because as you start to think about independent organizations working together, oftentimes those organizations will be at different points in terms of having developed their own infrastructure to address these types of challenges. So it's about finding things that really add value to the largest number of participants as possible, such that everyone feels as if the work of the network is benefiting essentially their contributions to any sort of value-based initiative that you might undertake. So we're going to talk about the variety of different service lines that we've seen networks develop. We're going to talk about certain types of support that they provide for members, options for staffing, the implications these have on budgets, and then the IT and data considerations for any of these types of projects that are being undertaken throughout the country. And then we're going to leave you folks with some information about how to create the work plans for effectively implementing networks, which will include a homework exercise that we'd like each of your groups to do before our next session. Building a network is very much an exercise in building a business. And in particular, there's got to be a lot of considerations for the financial sustainability of that network as it relates to the marketplace that you're operating in. And I want to start by saying that there's a variety of different models, a variety of different network types, and all have different expectations or requirements of the participating providers in terms of what role those providers play in financially sustaining the network. But we can draw some immediate guidance from historical approaches that generally speaking, networks are most sustainable if they have a diverse set of funding opportunities, not just self-funded by the members, and if they have a long-term vision for how their services will align with new payment methodologies, which ultimately help make them more sustainable and successful. There's also been a variety, and will continue to be a variety, of funding opportunities around the safety net that may or may not be effective or even allowable to invest essentially in these networks. And so we like to try to make sure that the organizations that we interact with really understand the types of things they'll need to develop over time through a network for that network to be sustainable, so that any and all funding opportunities essentially can be on the table as they develop their long-term plans. A couple of things to note in terms of how these networks work. We've talked already about the fact that most networks will need to establish or maintain some level of standards that are typically more encompassing than the standards that we associate with membership associations. So if you're, likely everyone on this call is either in some type of statewide association, whether that's a hospital association or primary care association, or maybe even in a regional association, you know that there are certainly participation standards to being in those organizations, but those organizations are historically not directly involved in helping you manage your payment methodology at the contractual level. And there's a variety of reasons why they don't do that, but one of them is because they're not really a clinically or financially integrating body. If you were to think of these networks as essentially helping you to integrate with other members to get the best possible payment methodology in terms, then you really need to have a set of standards to support essentially your claim that you are in fact integrated. And since every single organization that might participate in a network will be coming into that relationship at a different point in their own evolution, it's impossible to state that everyone will essentially stay on course or even be willing to participate at the onset. Allow me to give you an example of this. A network might form with a contracting philosophy that they intend to be a fully patient-centered medical home recognized network of providers. Well, by establishing that as an opening standard, they already have eliminated any of the organizations in their market that have not gone through the process of becoming recognized. And maybe by creating that network, they'll create a motivation for other organizations to become recognized, or maybe those other organizations that aren't recognized may just choose not to affiliate with that network at all. That is a very common opening platform that a network will create that clearly implicates its standards. Governance, as we discussed last week, does need to be representative and nimble. And part of the reason for that, as we'll explore today, is that the governing body of any network is forced with facing two very important, really kind of day-to-day activities. One is managing the relationship with the outside world in terms of who's paying the network or the network members, and the other is managing the development of the internal operations of the network so that the network is effective in helping its members meet those outside expectations and terms. And this can be fundamentally challenging. Creating participation agreements and financial arrangements, those are really necessary so that folks understand what it is they're signing up for. So when an organization joins a network, it's very clear to them what's expected of them, what they'll be provided by the network in terms of support, what they may or may not have to pay for the support that they get from the network, and what other financial benefits might come to them as the result of being in the network, perhaps through contractual arrangements with payers, perhaps through an ACO-like arrangement with the state, et cetera. A lot of the pressure that we're facing, both at the federal and state level, have really put us in a situation where we don't always have the benefit of thinking through these issues maybe with the same time horizon that we might like to. We've often used the example of Illinois. Illinois moved very quickly to implement a provider-led and a private managed care program, so they had a dual program, and that happened, or that was implemented over the course of a very short period of time. In the state of Iowa, as an example, Iowa moved from a Medicaid ACO model to a private managed care model in just under, I believe it was 18 months. And the safety net providers in both of those states really had to think through how they wish to interact with networks, whether a network they formed themselves or a network that was sponsored by some other entity or organization, on a timeline that quite frankly didn't feel all that comfortable as the result of the way in which the state rolled out its value-based purchasing plans for Medicaid. So we want you to understand these concepts even if you aren't quite yet at the point of formally developing or building a network. And today we're going to talk about what lives within that network in terms of services provided either to its members or to others via contractual relationships. A couple of things, again, really start to set the stage for today's conversation. There's a lot of things that can help be predictive of whether your network development activities are going to be successful. And I'm going to walk through each of these and give some examples. The first and very important is early role clarification. A lot of times, as we'll discuss, there's existing capability within your market or region to provide some of the very services we're going to talk about today. So, for example, if your network model relies heavily on the exchange of clinical data, what role will the regional or statewide health information exchange play in delivering that service? Or if your association, a statewide hospital association or primary care association or other association provides a set of services around data analytics, is there an expectation that that will be the data analytics platform that will be used to analyze data from the health plans or from the health care providers? Getting this out of the way, making sure it's clear, and even going as far as to formalize the roles through memorandums of agreement can prevent or eliminate the potential for a lot of heartburn later. When all of a sudden the network decides to move forward with a funding source that will allow them to essentially invest in capabilities or technologies or services, that it was clear up front that those will be housed within a certain organization or entity. It's important to align priorities and expectations. We've seen a lot of great models, and we've seen organizations develop a lot of great capacities or services, only to find out that there wasn't enough interest from the members to buy into those services. And a good example of this that we've seen happen before is around credentialing, where the network has a rock-solid business plan for why it should be credentialing or become a delegated credentialing organization on behalf of its members, only to find out that most of its members are already a part of another delegated credentialing organization. So making sure it's clear that if the network is going to build capacity in a certain area, that there is an expectation that the members will come along and buy into those services. There needs to be a shared understanding of the network model construct and its opportunities. So specifically, or to give an example, making sure it's clear that the net, based on the types of contracts that a network might seek, that it's clear what type of internal capacity it's going to need to meet those. You don't want to enter into a sophisticated, capitated, or shared savings type contract that heavily depends on an ability to analyze claims data, only then to leave the network participants to do that on their own because the network doesn't have that capacity. We spent a lot of time talking about effective governance models. I'm not going to belabor that point today, but we kind of always point back to the fact that unlike member associations that often have a very large representative governing body, these need to be more nimble, and they need to be able to respond really on a timeline that's much more aggressive and frankly can feel at times grueling. And so an effective governance model is important. Availability of data, and interestingly, I think to many folks, at the early formation of these types of networks, it's less about external data and more about the sharing of data from the organization's members, the network's members, to the network. I'm going to give you a perfect example because I've just finally started sleeping well after last week, where we were involved in the creation of several new Medicare Shared Savings Program ACOs. And under that model, each organization participating in the ACO needs to provide a significant amount of billing information in terms of how their providers bill Medicare. That needs to be done in a consistent fashion. It needs to be done on a timely basis, periodically throughout the program. And the ACO must update or manage that information with Medicare in order for the ACO contract to essentially be administrable. Well, not all organizations are at the same level in terms of understanding how to get that information to the network. And an inability to do so in an efficient fashion can really hamper the network's ability to enter into the type of relationships it wants. In fact, not getting that information in by the deadline, which was July 29th, so just last Friday, could have made it an ACO ineligible to participate in that contract. So sharing information freely across a network is critically important. We've often suggested that even if there are opportunities to receive external funding support for network activities, that all parties, and specifically all network members, should have some investment in the process, even if it's relatively nominal, because you have other ways of funding the activities. It does create essentially the skin in the game feeling of being willing to put some money at risk for the greater good or for the benefit of the network and the long-term value that the network provides back to its members. And then ongoing and committed member participation. And again, we talk a lot about this in the governance section with getting folks involved in committees and really understanding that most of these networks need to be lean from a staffing standpoint, at least initially. And so that puts some of the burden back on those participating to contribute to the effort and doing so in a consistent fashion that's considered to be fair. Any questions or comments now that I've kind of walked through some of the high-level discussion that we'd like to have before I move forward? Okay. We've talked through various aspects of these 5 categories or areas throughout the conversation so far. But really today we're going to start talking about how the mission of a network ultimately starts to define the business lines or service lines that it needs essentially to deliver on that mission, how it goes about identifying partners to either help build those business lines, invest in those business lines, et cetera. Virtually nothing happens in the healthcare world these days without a focus on how to get the right data in the hands of the right people at the right time. So every one of these service lines will have some element or need for data and IT infrastructure. some more than others, but virtually every service line has an expectation of having the availability of data. Most networks, particularly those that intend to clinically integrate, but even those that intend to financially integrate, need to establish some coordinated clinical programming, and the network must select performance or other metrics for reporting. In some cases, those are dictated by contracts. In other cases, those are selected by the members and then used essentially to go out and get the types of contractual terms that they want. So a typical process for going through those stages begins with analyzing the impact of the network. We will often refer to this with our clients as developing the business case. What is the case for working together? And typically that business case needs to be articulated in terms of financial benefit, clinical benefit, and benefit to the patient experience. Three things that I'm sure you're very actively working on because they align closely with the triple aim. So until the organizations that are coming together to form a network can clearly state how they intend to use their participation to improve either financial outcomes, clinical outcomes, or patient experience outcomes, ideally all three, there's really no business case for working together. And once you've identified that business case, now you need to make the decisions around how to manage essentially the development of the network through the governance models. But you are also ready to begin prioritizing the type of business or service lines that are going to support achievement of that business case. So for example, let's say that you wish to improve health outcomes associated with a chronic disease population living in an isolated part of the geography served through telehealth. That would be your business line with a goal of either improving the health status or reducing the cost or improving the patient experience. But the business line will be the telehealth solution and how it is delivered to the members. Once you've identified that business line, there's a second key process that goes into essentially validating the business case. Does the investment necessary, is the investment necessary justified by the improvements we can make in health outcomes, cost of care, or patient experience? And what level of upfront investment do we need to make this work? One of the biggest challenges that new networks will face is that as they'll find a very significant requirement to make capital investments that often aren't repaid until the network has operated for a period of time. So identifying the ways to essentially get those capital investments paid for is critically important. The next step really involves the engagement of legal or other knowledgeable resources to help make sure that you're walking through this process effectively. In this step is the development of things like the operating agreement for the business, the creation of a new entity if it's necessary to operate as a network, evaluating your strategy for staying out of antitrust trouble, creation of participation agreements that actually bind the members of the network to its services and to its operations. So there's a fair amount of things that go a long way towards helping us formalize the commitments that we've made to one another. And at that point is really when you're ready to begin operationalizing and actually building out the set of services within the network. It's not always quite this clean. It's not always a perfect stepwise process, but these are the types of things that we find help make the experience of developing these types of networks, first of all, more likely to succeed, but also a lot less painful on those involved in actually developing and building the network. I'm going to start by talking about who the key partners might be in a network development process. And certainly the most important partners are the underlying healthcare provider organizations that are going to participate in the network. But beyond those, there are important external partners that may need to be involved. For example, are there existing networks already operating in the state that need to be engaged in order to do this work effectively, but also to get to the point where we're delivering services efficiently? The federally qualified health centers on the call will probably have some experience or at least know what a health center controlled network is. These were Bureau of Primary Healthcare funded initiatives to develop networks largely focused on information technology capacity, although not always. And these are existing bodies operating within their given geographic area. Oftentimes, they provide an extraordinarily good starting point for the development of the services necessary to administer a contracting network, like an IPA or an ACO, but in and of themselves are not typically the appropriate entity to use to be the contracting network. So how do we get them involved in a meaningful way that capitalizes on the investments they've made, utilizes the staff that they've developed, and frankly provides a sustainability plan for them once their grant funding goes away? These are important considerations to begin discussing upfront. Once we've identified those types of partners, are there other services that we need? Is there additional capital that's required to fund those services? There are a lot of businesses out there now, and we will not name any because that's not our purpose or role, but there are a lot of businesses out there right now that are very interested in working with the safety net on alternative payment approaches, specifically the Medicare Shared Savings Program, but certainly state-level managed care engagement or state-level ACO engagement, who can bring things to the table. They can bring capital to the table. They can bring people to the table. They can bring information systems to the table. But they do it at a trade-off of either wanting to participate in the financial upside or wishing to own a significant piece of the network itself and have a lot of control in the decision-making processes of the network. So as you identify the types of services that your network needs, if you need to look outside your direct organization, you may find that there are organizations out there that are willing to help you, but you must understand essentially what the trade-off is for doing so and engaging with an external partner. We talked about performance indicators a little bit, but I want to kind of tie it back because I think it's so critical to addressing that challenge of ultimately achieving a business case for coming together. So even if you're a network that has no contracts with health plans, has no contracts with the state, or isn't in a Medicare payment arrangement, it's still critically important to have performance indicators because your business case is predicated on improving outcomes, decreasing costs, or improving the patient experience. And depending on wherever you focus, the population you focus, the disease state you focus on, the geography you focus on, there will be indicators throughout the course of the process that will help evaluate whether you are trending towards accomplishing those performance indicators. Or those broader goals, and those are your performance indicators. So even if you aren't forced to adopt any performance indicators, networks need to do so that they can evaluate their performance over time of achieving their business case. And how do you do that? Well, mostly through the use of some type of IT infrastructure. There's, again, no one-size-fits-all IT infrastructure that supports all networks, but I'll talk a little bit about some of the trends that we've seen that have been critically important to supporting many of the networks that have been successful. One of the key areas of need for most safety net provider organizations really seems to revolve around enhanced analytics and reporting capability. We're operating in an environment where electronic health records have provided us with a wealth of information, some of it very helpful, some of it very confusing or not that helpful, and the ability of a network to help make sense of that information across multiple organizations can be extraordinarily impactful. And so typically they'll do that through some type of data centralization or aggregation program, and that data centralization or aggregation program will involve having centralized staff who can then help interpret that information and turn it into actionable, meaningful information back to the partners. But EHR data is just the tip of the iceberg. We're now also being expected or asked to manage with information about cost and utilization, which typically comes from claims data, either from the payer or from the state. Most safety net provider organizations we've worked with, in fact, the overwhelming majority, over 95% of the organizations we've worked with, have no infrastructure and in most cases no experience working with those types of data sets. And then when you start taking into consideration data coming directly from clinical partners, like information passed between a hospital and a rural health center, for example, about the patient's use of the emergency room, there are a lot of new data sources and a lot of new opportunities to use this information. But in most cases, the provider organizations themselves are going to need help essentially to maximizing the value of that information, technology, and data. All networks, as I mentioned earlier, whether they intend to be clinically integrated, financially integrated, or not integrated at all for the purpose of contracting, still tend to benefit from development of some level of shared clinical programs. This can be as simple as agreeing upon certain clinical pathways or evidence-based guidelines that everybody agrees to implement, or as centralized and robust as actually having a certain level of the clinical delivery staff as employees of the network and working on behalf of the network members. There's no right or wrong answer to this. But again, some of the networks that have been most successful have worked closely with their participating provider organizations to really understand the gap in skill or need as it relates to new models of care. Many have developed programs to help train the clinical staff at the various organizations on how to implement the types of interventions that are going to be successful in achieving the triple aim goals or the mission of the network. And some have gone as far as to supplement staff within the organizations because those organizations have no intention of hiring staff or the ability to hire staff possibly because of their size. A good example is a network of safety net providers operating in the St. Louis market that have essentially created a referral program back to primary care from hospital emergency rooms and inpatient stays that attempt to address social determinants of health for the Medicaid and uninsured population such that their return to the community and their return to care being delivered in the ambulatory setting is as supported as possible by social service agencies that can help them address certain barriers to their wellness. In this particular model, there are employees of the network that operate within the hospitals and within the ambulatory care facilities. But no model is, there's no such thing as a one-type-fits-all model. Now, this last area of discussion really revolves around the services necessary for organizations or networks that truly intend to go out early in their evolution and secure the best contracts with payers directly, whether those are private payers like Medicaid managed care, whether that's CMS, or whether that's the state directly. In the case where the network has immediate goals of signing contracts or negotiating contracts, virtually all networks in that case will house their contracting and contract management expertise centrally. These are skilled or experienced people that can enter into negotiations on behalf of all participants. They can evaluate contract offers and help each member of the organization of the network determine its financial impact. They'll assist in closing gaps in performance that lead to better payment terms and better health outcomes, and then create ongoing processes to support overall achievement of the contract's financial triggers. So making sure that we have a long-term plan for how to maximize the value of those contracts to really draw down as much financial resources as possible to serve the patients that the network members serve. This is a relatively typical timeline. Again, every network is different. Every network's participating organizations are coming at this from a different starting point. But typically, it can take anywhere from 1 to 2 years to go from the concept or the vision of a network to actually having a network operating. When we talked earlier, I mentioned that we're feeling pressure. We're feeling pressure from both the federal government, from our state governments, maybe from local government, or from payers in our market to do something, to organize differently to address triple aim goals. And oftentimes, the timing around that, or the time we're being asked to be responsive to those types of changes can feel very stressful. And that has a lot to do with the fact that these are decisions that need to be evaluated carefully over time with a very broad group of organizations coming to this from a different standpoint. And it's not comfortable to feel like we need to be responsive to a change in the payment environment that may be implemented within 4 months, when we've laid out here that best practice suggests it takes really anywhere from a year to 2.5 years to do this effectively. But we've tried to block out and lay out for you what are those phases, how long do they take, and how do you go from not having any sort of network to essentially operating as a mature network. And it starts with that evaluation or business case development, the structuring of the network, development of the governance model, the funding plan, et cetera, working towards development of the standards, implementation of the information technology to support that, and then ultimately getting out into the market and doing the contracting necessary to make it happen. And all of that work then to get to the point where you are effectively operating the business and now need to manage to those contracts. I'm going to take you through a little bit of information about each of the steps of those processes. The evaluation really relies heavily on understanding information about payer mix, information about general readiness, and then understanding the types of capacity that already live within each of the organizations. A network will not be successful if it tries to centrally replicate a set of services that its members already have in-house and are running efficiently. So it needs information, it needs to understand that as it builds that business case for essentially improving outcomes. We've talked a lot about the structuring aspects. I'm not going to spend a lot more time here, but most organizations do go through the process of forming some type of entity, developing a board and committee model, creating an operating agreement, figuring out how they're going to staff or not staff, and really rely on human resource contributions from its participating members, how it's going to fund, and then requesting that its members make some type of formal commitment and potentially that investment, that skin in the game that I talked about earlier. These networks take time. We kind of laid out for you on a timeline what it might look like, and to make it happen, it needs input from its members. In the success predictors on one of the very first slides, I talked about this. Without that information, it's virtually impossible to develop an effective or meaningful network. The network must also anticipate contracting priorities that will naturally have an impact on the strategic planning of its individual members, and likely impacts the prioritization of the individual members' quality improvement resources. And by signing up to be in a network or by taking on a new payment approach, even if it's to a very specific population, there's an implied commitment of resources to make that happen. But understanding that the network does then influence how the organization utilizes its own resources. There may be a need to capitalize the network beyond an initial request. A lot of networks get started with a very small contribution from those who intend to participate and use that capital basically to figure out their business plan, basically to figure out what services they're going to provide and how they're going to provide them and what they're going to cost. And really then and only then can they come back to the members and discuss the longer term costs of providing those services. And that's really the point in time at which the network's in really kind of the best possible position to seek that funding from the outside world, whether that be through foundations or other funders, or from payers directly. And networks typically will want to create an opportunity for folks to join after the initial opportunity. However, keeping in mind that the initial participants will have pretty significant influence or say in governance, it's really at that point that they have the decision-making authority as to whether to expand membership over time. Okay, I'm going to pause there. We have about 40 minutes left, although we do have a couple of things that we need to take you folks through as we start to get ready for the final session. But I'm going to pause there, and I'm going to see if any folks want to ask any questions or make any comments on what's been discussed so far this morning. Folks from the Mississippi Primary Healthcare Association, you guys have been down this road in terms of now operating under a Medicare Shared Savings Program contract, if I'm not mistaken. Can you talk a little bit about how you got your members to the point of making the decision to move forward, and then how you really kind of operationalize that and turn that into a functional business?
Andrew, this is Sonia Fuqua from the Mississippi Primary Healthcare Association. Can you hear me?
I can, yeah.
Great. Thanks for your question. And just so we don't ignore you as you are picking on us, the Mississippi Primary Healthcare Association, I do want to say at the onset that the persons that can best answer your question and articulate what we have been doing are not on the line. But just to let you know, We do have most of our centers involved with our ACO. As a matter of fact, one of the reasons our ACO guru is not on the call is because he's participating in an ACO meeting as we speak. But it's been a grueling process, I must say, to get everybody involved. And we started out with just part of our membership. And once we got results from the first year with favorable outcomes, we were able to sort of encourage some more of the members to get involved. We work closely with our universal, I'm not calling the right name, our organizer for our ACO, to make sure that we meet on a regular basis and see what our outcomes are looking like. We meet with our care coordinators to see how they are working with our various different health centers. But it is something that we have to really be committed to as a PCA, to constantly pull the centers together, to have the quality meetings and the management meetings as we go forward.
Right. So I'm just going to recap a couple of things I heard you say and make sure that I heard them correctly. So there's in terms of selecting a partner, you're working with a third party that has a lot of experience in how to run an ACO. Is that correct?
Exactly. Okay. And that's what we have been doing up to this point, not made a valid decision as if we will continue along that vein as we go forward. We are looking at establishing an independent practice association.
Okay. And you also mentioned that one of the valuable approaches that third party takes with you is to come and review data and work with the care coordinators. Are the care coordinators employees of the network, or are they of the ACO? Are they employees of the third party entity, or are they employees of the health centers?
They are not employees of the health centers of the PCA. They are part of the third party vendor.
Oh, I see. Okay. So those were all considerations that you made when the group was really coming together that have an implication essentially on the infrastructure and the operations of the business. And that's really what I wanted to kind of illustrate to folks. So thank you for allowing me to pick on you a little bit.
Well, thank you, and I hope I was able to share some valuable information. As I mentioned, I'm not the ACO guru.
Yeah. No, thank you. We appreciate it.
All right. Thanks, Andrew.
Thank you. Any other group have question or comment at this point?
Yeah, we just had a question. This is North Country. We had a question about the power of attorney delegation for these contracting networks and how that really works, if you can touch on that a little bit.
Yeah, we can talk a little bit about that. So networks can establish, they're legally allowed to establish different levels of essentially delegated authority on behalf of their members. Some networks, and these networks tend to have a harder time contracting in the market, can negotiate terms, but then their members have to sign off on the corresponding offer that the network makes to the members. So let me explain. Network goes out, gets a contract with a health insurer that says, we're going to pay you $3 per member per month. Now the network goes to each of its independent organizations and says, hey, who wants to sign up for this deal where the network gets $3 per member per month, and we're going to pass, say, 2.5 to you. I'm just using hypothetical numbers. Now the members have a right to individually sign off on that corresponding contract. Those kind of relationships can work, but it's a lot harder to get the network interested in essentially in a negotiation, because they don't have the commitment yet of the participating organizations that they'll sign off. What you're talking about is a power of attorney delegation that frankly allows the the network to bring any of its participants directly into contracts. And that's about as strong of a commitment as you can make to a network. What that means is that should the network deem the contracts to be appropriate, that signing off on behalf of the network bind each of the participating organizations that have delegated their power of attorney to the network. Now, that can be done in a lot of different ways. Oftentimes, there'll be kind of a set of terms and conditions around delegating power of attorney to a network, so it's not essentially unilateral power of attorney, but there's essentially some limitations placed on it. But it is an important consideration for any network, because when a network enters the marketplace with the legal authority to sign its members up for contractual terms, they have a lot more leverage in the marketplace. Was there a specific aspect of it that you wanted me to focus more on? I want to make sure that I kind of thoroughly answered your question.
No, you touched on what we needed. Thank you.
Okay. Okay, so we're going to now spend a little bit of time talking about how networks go about building their shared infrastructure. This is going to lead us to your homework assignment between this week and next week. And then we want to also talk about Session 5 before our time is up today. So an integrated network, whether it's financially or clinically, one of the litmus tests that's applied is whether the infrastructure of the network allows its members to perform differently than if they didn't have that infrastructure. So, for example, if a network was to provide, for example, an analytics capability that the participating organization didn't on its own have, that alone doesn't prove integration, but it certainly would be one test as to whether that network was integrated. You heard in the example that a network may choose to use a third party that could bring skilled care coordinators to work on behalf of the participating organizations to help improve patient outcomes by demonstrating that the members of the network get that care coordination capability that maybe they didn't have before would demonstrate essentially some level of integration. But shared infrastructure creates costs, and ideally, because those costs are being shared, some level of operational efficiency. If each of you had to go out, or each provider organization represented had to go out and hire an informaticist and purchase sophisticated analytic software, that's probably less efficient than if a network does that on behalf of its members and then offers that as a service. And the infrastructure, shared infrastructure, may be accomplished by establishing infrastructure directly within the network or through an arrangement between the network and some other type of organization. And we have an example of that, or we heard an example of how a third party delivers some of the services that the network needs. And again, there's no one-size-fits-all model, but that can be a very efficient way of reducing some of the timeline necessary to get to the point where the network is operating efficiently. We've listed here some of the types of shared infrastructure that fall into the clinical, financial, and operational domains. In the clinical domain, we have shared, for example, shared QI staff or even shared care coordinators. We might have a network function to develop guidelines or adopt guidelines and then help implement them. Or we may have shared IT, clinical IT capabilities. Some networks have integrated purely around the fact that they host an electronic health record for all of their members. In other cases, this might be analytics. In other cases, this might be health information exchange. In the financial realm, we have seen networks that have built shared infrastructure around improving the efficiency of back office processes like billing and collections, commonly referred to as the revenue cycle. Others might utilize a shared CFO. So each member organization gets insight from a high-level executive that really understands the managed care environment and the financial realities of the contracts they're in, but not every organization needs to maintain that capability. Or they may develop shared financial policies and procedures procedures to simplify and streamline their operations. In the operational realm, they may develop shared payer relations functions, which could include network-level credentialing or the network handling pre-authorization and referral processes on behalf of its members. They may have shared scheduling functions. They may move towards more consistent practice management systems and capabilities. They could even create a centralized call line for patients seeking care for the first time and then help assign them to one of their network members. Or they simply could have a shared project management function, something that helped each of their participating organizations implement various standards or requirements of the network at their local organization. These are just examples, and not every network will have all. Certainly, most networks won't even have most of these. We just wanted to illustrate some of the breadth of the different types of things that a network might undertake as part of its shared centralized infrastructure. We are going to talk a little bit about this through the lens of the Medicare Shared Savings Program. And certainly, for organizations operating in the safety net, Medicare may be an important payer, but a lot of times we're more focused on Medicaid or the uninsured or other populations of patients. So why look at Medicare? Well, because Medicare has created an important template that we feel has propagated pretty effectively through Medicaid and other payment reform methodologies. And also because the Medicare Shared Savings Program offers a fairly significant protection from an antitrust standpoint, largely because when Medicare approves the application of an organization entering its shared savings program, it is more or less deeming it to be an integrated organization. So as a result, we feel it provides a fairly good set of milestones for the type of shared infrastructure necessary to operate an integrated network. There are 4 key aspects that the Medicare Shared Savings Program requires for an organization to be allowed into the program. It must, as a network, demonstrate an ability to promote evidence-based practice. It must show the ability to support patient engagement. It must demonstrate an infrastructure that supports performance management and reporting, and a consistent plan for care coordination. Now, I want to talk a little bit about how this can vary because there are no one answer to how networks should address these needs, but networks should address each of these needs. Ability to promote evidence-based practice. Can the network demonstrate that it is effective in selecting evidence-based practices and helping its members adopt and implement those? But that can be everything from simply providing them to the organization to actually hosting electronic health record systems that enforce those evidence-based practices and guidelines. Supporting patient engagement could include the ACO or the network itself directly engaging with patients, or simply providing the tools and the data and information for the members of the network to engage their own members. Maybe the network has its own brand, or maybe its brand is not very forward-facing to patients. Supporting performance management and reporting could involve a sophisticated centralized IT system to do this work, or could simply mean having a shared analytics or informaticist who goes out to each of the organizations and works with them hand in hand. And a consistent plan for care coordination could involve centrally housed care coordinators, as we heard about earlier, or a training capability to help the care coordinators located at the participating organizations become more effective in working with the network's patients. So again, no one-size-fits-all answer, but the Medicare Shared Savings Program does start to help us focus a little bit on the types of infrastructure that, frankly, all networks should consider having. Last week, Amanda talked a lot about integration and specifically elements of clinical integration. I wanted to just kind of revisit that the 7 elements that she discussed fit into this equation pretty closely. Those in the gray are things that typically an organization's operating agreement or bylaws will dictate what type of legal entity is being used to serve as the network and how are clinicians involved in the leadership of that organization. In orange, really determined by what we would call a participation agreement, which is a clear set of expectations between the network and the participant about what's expected of them and what happens if they're successful. But the elements in the yellow really form or are the most important areas for there to be shared development of development of shared infrastructure. The performance improvement, managing to performance expectations, the information technology needs, and the joint contracting really are the sweet spot for a network's shared infrastructure. So how do you fund this? There's really a couple of different phases that you'll go through. Funding this type of development is not as simple as figuring out what it's going to cost. The initial budgets really need to be focused more on answering some of these key questions as to what is our infrastructure going to look like and what is it going to cost. So initial budgets are really focused on what are our legal costs, what are our costs to get into our initial contracts, what are our costs for administrative support, and the capital necessary to make some of the infrastructure investments that we need. Funding that budget, we mentioned you have a variety of different ways of doing that, which could include outside funding, but often include support from the participants. And even if the long-term financial reality of your network is that you expect payer revenue to make it sustainable, it's not realistic to expect payer revenue really for the first 12 months of forming a network. So you have to look outside either grant funding, capital investments from the participants, or in the rare cases where contracts may offer upfront investment, like the Medicare ACO investment model that was an opportunity that expired last year around this time. Those were ways of essentially funding it ahead of having the payer revenue to sustain it. Budgets should include conservative estimates of revenue. We often, in helping organizations understand their infrastructure costs and needs, and then also how those are going to be essentially repaid long-term by new revenue sources, we tend to be extraordinarily conservative. So conservative that at times the break-even can take several years. But in doing so, making sure that we're really creating something that has a very, very high likelihood of financial sustainability. All networks should work to really push as much of the revenue back out to its members. Just a quick comment on that. Most networks don't capture your core billing, so you're going to continue to bill most payers and be paid by most payers. So it's not that revenue that we're talking about. It's any kind of pay-for-performance or care coordination revenue, and they're going to want to distribute as much of that back to their members. So your budgets need to account for those distributions, but it can't distribute essentially 100% of the money because the network needs some of that to support its sustainability. And in the case where the participants did present upfront money to get the business off the ground, you will want your budget to reflect some opportunity to recoup that initial investment. Real quick, because we kind of talked about this quite a bit, common infrastructure elements for performance improvement include data aggregation or data warehouses and shared staff to essentially use that data information. May or may not include shared care coordination. capability. A lot of times organizations prefer to decentralize that, make that a function that occurs at the organization level and not the network level, but the network still needs some capacity or capability to help support that locally. We mentioned that a network level clinical program is pretty much required, even if you're not immediately looking to contract together. And that's just because the ability to do this work really is predicated on improving patient outcomes, clinical, financial, and experiential outcomes. The goals of existing and what existing infrastructure might exist really determine what types of additional programs.
Hi, everyone. Hey, Andy, I don't know if you can hear me, but it seems like the audio is gone from your side.
AJ, are you able to hear me now?
Yep, you're back.
Okay, apologize for that, folks. I don't know what happened here. Again, this budget I would not use necessarily to, be in any way predictive of what your costs might be. However, it does kind of break out some of the major categories that we advise organizations to budget against. Governance and organizational setup is things like forming the organization, writing the operating agreement, legal work, legal filing, stuff like that. Clinical and revenue cycle assessments really get at understanding what are some of the shared needs that the network might be able to assist its members with so that it can create some of that shared infrastructure. And then you see things around incentive or pay for performance-based contracting, ultimately moving towards fully integrated contracting over time, the development of a payer relations function that include referral and pre-authorization management, shared savings program, entering the shared savings program, and administering the shared savings program. And then that really big line that says clinical data aggregation with a $1.2 million investment over a couple of years. But this is a pretty realistic breakout, not necessarily of the cost, although there's a lot of variables that go into that, but a pretty realistic breakout of what an organization might need to get itself up and running over the course of 3 years. The clinical data aggregation is not reflected in the total expense budget at the bottom because it is that's funding that they're seeking from the outside. This group is seeking from the outside. Now, I will say, in some cases, some of your projects might be so limited in scope that these numbers look terrifyingly big. But in other cases, these might be the type of numbers that really are realistic given what you're trying to accomplish in your particular region. So don't walk necessarily out of here saying that these are the exact numbers you would need to start a network because every situation is different. I mentioned that you need to be very conservative in your revenue projections. This shows a very simple revenue projection mechanism of $3 per member per month across 5 health plans that a network of providers had considerable numbers of lives in. And it can show you how even relatively small per member per month payments can have a big impact on a network's budget and operations. In this case, we mentioned how payer revenue is theoretically the financial sustainability plan long term for these networks. In this case, the network is distributing roughly 80% of every dollar that comes in back out to its members. That's not a benchmark, that's not a goal necessarily, but it really does depend on what is the centralized infrastructure that needs to be paid for out of that network. Shared data and IT, we've talked quite a bit about. EHRs, registries, other data analytics tools, and some networks will get by simply with establishing data standards and then looking to do service some capability of aggregation of data. Joint contracting is the last one, and that's really the one that's focused on obtaining the payer contracts that improve financial resources to all participants and create the integration around essentially improvement of clinical and financial outcomes. We've talked about it can be done either by network staff or some kind of external advisor, typically overseen and guided by the governing body, that board. But it's an ongoing process. It's something that never really goes away. And the network wants to develop more and more with each contract period, wants to develop more internal knowledge about the process and how to execute the process. Managing of the contracts is the goal of, the process of understanding the contractual terms, the pay-for-performance terms, the shared savings terms, whatever they might be, and then advising both the network board as well as each participating organization how to maximize the value of those contracts. Here's an example of a very common network configuration where a small staff reports to a board. That staff oversee 3 internal infrastructure functions: quality and data infrastructure, which is staffing and quality coaches, as well as some information technology systems to support quality improvement and data improvement, contracted services for admin. This is simply the fact that as a freestanding entity, this network needs finance and admin support and support for other functions. They subcontract that out to a third-party entity, and then contract review, contract negotiation, this theoretically would be enough of an infrastructure for a freestanding network between the contracting, negotiation of contracts, and the quality and data infrastructure. Now, that alone, you'd need a lot more detail to determine their level of integration, but this would be essentially enough of an infrastructure for a freestanding network. Okay. I'm going to introduce to you two concepts, and then we're going to build towards your homework for this coming week. We think it's critically important that networks in the early formation develop a work plan that guides their year one activity. Very difficult to answer important questions like, what should our staffing be? What is our budget? How much money do we need to raise? Without laying out at least 1 year's worth of activities. And these activities will often include things that really are defined by the startup of the organization and don't need to be sustained or done time over time. But by the end of year one, you'd want to be in a position where the organization is relatively freestanding. Really, really detailed. Hopefully you could see this more in your home or take-home copies of these slides. But this kind of laid out the milestones. And this is a roll-up from a much more detailed document that talked about what went into each of these steps, but kind of lays out as milestones when certain tasks needed to be completed over the course of the first 12 months of a business's operations. So the tasks are broken into new entity development staff, contract negotiation tasks, and then clinical and financial integration tasks. And you can see that each task was overseen by a different aspect of the governing body with milestones due at different points throughout the year. And since there's a lot of interdependency between these tasks, failing to hit one of them really could create some challenges in the network achieving its overall goals. Okay, in a second, I am going to switch to a document that we've used successfully with a lot of our clients. We've made it, I think, a little simpler because we know not everybody's, very formally in the network development process. But it's a document that we would like each of the represented organizations on the call to take back and spend a little bit of time with the leaders in your organization that are participating in this process and come prepared to discuss it as we kick off the 5th session in 2 weeks. I'm bringing, AJ, are you able to bring up the Session 4 infrastructure document? Perfect. We got this worked out this week so that we are actually in a position to show you these. We are simply asking that you spend a little time with your team talking about in a key set of key infrastructure areas like the setup of a new entity, like the financial controls, like legal support. What would be your current capacity? What would be your gaps? And then how would you go about addressing those gaps? It's only 2.5 pages in length. We don't think it'll take you necessarily a lot of time, but we do think it will be a valuable exercise for you in terms of thinking through how the creation of a network might roll out in your particular case. We understand that not all of you are very actively involved in creating a network at this point. We also know that some of you have already created networks at this point. But we are looking for you to spend some time, regardless of where you are in the process, completing this and then coming back with some of the lessons learned and the experience that you've had in doing so. And we will be calling on you to share some of your experience. So please, if you can spend some time between now and 2 weeks from now, that would be extraordinarily helpful. AJ, you can go back to the presentation. And I'm just going to stop quickly. We're running out of time, so I want to get to one second piece of homework. Any questions or comments on the group exercise? Okay. Second to the group exercise, the entire duration of next week's call will be focused on the dissection or breaking down of a case study of a safety net network that came together specifically focused on improving outcomes and negotiating contracts that essentially rewarded them for doing so. I'm going to show you the case study in a second, but in order for next week's session to be valuable and useful, it is important that you spend some time with the case study. We've kept it brief. It's not an extraordinary, it's not a long reading assignment. Why don't you go ahead, AJ, and bring up the case study? Okay. So this case study lays out, and this is actually based on a very real experience, it lays out a series of environmental factors that triggered essentially the need for a group of safety net providers to come together and develop a network to respond to those environmental factors. We'd like you to read about those environmental factors, and then we'd like you to work again with the leaders in your organization who are part of this process, part of this virtual learning process, to discuss how you might respond to those environmental factors, including what type of networks might support safety net providers in the environment described, how you would see your organization playing or not playing a role in that type of network. Would this be a good opportunity or a bad opportunity for safety net providers? How might you consider working more closely with organizations like your own or would you want to look at working in more verticalized networks that had a lot of different types of providers? And what are the infrastructure components that you would want, based on where you stand today, to support you in operating in this environment? We think this can be a rewarding experience for you to think about, particularly those whose states may not have moved very aggressively to implement new programs in Medicaid or for the uninsured. This is exactly the type of exercise that a group of safety net providers had to go through probably a little more quickly than they would have liked to, because their state moved very quickly. So we want you to kind of experience a little bit of that that almost stress that was created for this group of providers by understanding what's going on in their environment. We can jump back to the presentation, and I'm going to ask if we have any questions on the 2 homework assignments. Okay. The last thing I'll mention, we don't have a slide for it. The final session is only 4 weeks away. We need your presentations. You'll be making presentations as a team. So each of the organizations represented will be making a presentation. Those are due to us by August 24th. They'll go to Amanda, whose email address you can see on the screen here. We'll have a little work to do to get those essentially organized and all in the same format and whatever. So we do need those back by the 24th. If you have any questions in the interim in terms of how to complete those assignments or the homework assignments we just gave you, you have our contact information, and we look forward to assisting you. With that and the final couple of minutes we have before we're going to let you folks go, I just wanted to see if there were any last-minute questions or comments from folks.
This is Marty from Arizona North Country Healthcare. I do have a question about the presentation.
Yes.
Do you have a template that we're to be using for our presentation?
There was in the session from 2 weeks ago, we provided a guide about kind of what should go on each slide, but you're welcome to use your own slide deck template. But we did provide basically a way to frame up those presentation slides, but you're welcome to use your own template for that.
Are you talking about the Network Development Action Plan?
No, I'm talking about, yes, Network Development Action Plan informs the presentation that you guys will provide at the end of the session, at the 6th section. You'll pull information out of that document and put it into a brief PowerPoint slide deck.
Was it at the end of which section? This is Kim. We're just trying to find that information in the. Was it in the slide decks from the sessions?
2 weeks ago.
Right.
Okay. We're already working on the Network Development Action Plan. We're already working through it. So.
Perfect.
All right. Thank you.
Uh-huh.